So I just want to know what will be the questions you will ask. Somebody has come with insidious onset of bilateral pedal edema, abdominal distension, and reduced nausea. What other history you would like to ask?
Sir,
The one you said is bilateral. Is it pedal edema first or abdominal distension first? Okay.
yes, sir. So second, I would also like to know the amount of the distension, whether it is causing breathlessness or not, sir.
Very good.
I would
Then,
like to quantify the distension.
then, is there any pain?
Is there, yes, sir.
Is there any abdominal pain? And when there is pain, what would you like to know?
So the characters of the pain, sir.
So here is a 70-year-old man who has come with abdominal distension, pedal edema. Okay.
Yes, sir.
So one is the pain. In the pain, what would you like to ask?
So the site of the pain, sir. Site of the pain, intensity of the pain, character of the pain, whether there is any radiation or not, whether there is any diurnal
The pain,
variation or
is
not.
it a dull pain? Is it a dull, boring pain? Or does it come with intermittently acute episodes of pain? Does it related to food? What is a precipitating factor? What is a relieving factor? Was the pain associated with vomiting?
Yes, sir.
Isn't it?
Yes, sir.
And did the pain come? Pain was preceding these symptoms, the symptoms of abdominal distension, pedal edema, earlier than this. So these are important things you need to ask when there's no pain. Okay.
Yes, sir.
So here I would ask for a pain, and if there is a pain, if there is no pain, it's okay. If there is a pain, I would like to know how long, what is the duration of the pain? As you said, where is the site of the pain? What is the character of the pain? Was the pain dull, boring? And as you said, was it radiating to the back? Was the pain precipitated by food? Is the pain associated vomiting? And does vomiting reduce the pain? All these things. Does the distension reduce the pain? So these things we need to know. Okay? Because if the pain is dull, boring, aching pain, preceding these symptoms by 2 to 3 months, we know the pain was probably was probably a very significant component of this history, isn't it?
Yes, sir.
Okay.
Yes,
Why
sir.
is it significant history? Supposing this man has come with, say, abdominal pain for 3 months, dull aching, increased by food, and now is associated with less food intake and nausea.
So given his elderly age, that could be some malignancy.
Correct. Could be a malignancy in the stomach or in the
Pancreas, sir.
good. Very good. So that is the important clue here. Okay. So we need to know what. So we believe that the gradual abdominal distension is ascites, isn't it?
Yes, sir.
Ascites and pedal edema. Okay, that is the important thing. So here he had a moderately gradually progressive. It has reached a moderate size when he was not able to take food. This is the time he presented to us, and the abdominal distension and pedal edema came together, and there was no associated pain. So it's important that. Any other history you want to ask with this? You said there was reduced food intake and nausea.
So I would like to know whether the food intake was, whether he didn't feel like taking more food or whether he had any
The
difficulty in
first important thing is as he got anorexia.
Yes, sir.
Isn't it? Loss of appetite. In which, where are all the loss of appetite with abdominal distension you can really get? Where all this anorexia is a very important symptom.
So any mass in the stomach, they won't be able to.
Malignancy in the stomach. That's the most important thing. The first diagnosis always will be gastric malignancy, where anorexia is the most important symptom. Apart from gastric malignancy, where else you can get anorexia as a major symptom?
So even in cases of pancreatitis, the patient will have decreased
Not
food intake.
pancreatitis, pancreatic malignancy.
Pancreatic malignancy.
Gastric malignancy, pancreatic malignancy. Where else can you get when you get anorexia as a presenting symptom. Hepatocellular carcinoma.
Yes, sir.
And if it is a female, if the female comes with, say, dyspepsia and anorexia, where else can you get it?
Female with dyspepsia and anorexia.
Hmm?
So female with dyspepsia and anorexia.
Yeah, where can you get malignancy which can present with dyspepsia and anorexia? Ovarian malignancy. Never miss an ovarian malignancy in a female who comes with you with dyspepsia. Okay?
Yes, sir.
So these are things why this anorexia is very, very important. So you need to expand on this history. When somebody comes to you with a progressive abdominal distension, insidious onset, bilateral pedal edema, you need to ask for associated symptoms, and then you do it. Yeah, go ahead, please.
So for fever, sir, what was the nature of the fever? Whether it was high-grade fever, low-grade
It was
fever?
a low-grade fever. It is not evening rise of temperature, but it was associated with a productive cough for 10 days.
What was the nature of the expectoration? Whether it was whitish or it was blood-tinged?
It was
Foul.
just whitish. It was not yellowish. And he had an onset of fever for the 10 days. Yeah.
So along with that, whether he had any breathlessness or wheeze?
No breathlessness, no wheeze. Okay, so he had fever. We don't know. We don't have much other information on fever. History of intermittent on and off blackish tarry stools since 10 days. So here is a man who has got progressive abdominal distension, bilateral pedal edema, fever, and blackish tarry stools. That means he's got a melena, isn't it?
Yes, sir. So would want to know whether he had any associated giddiness or postural hypertension following these episodes of black stools.
He was feeling fatigability, but I'm not sure. I need to check in the next slide whether he has had it. But what other symptoms? So once in these, you need to know about the postural symptoms. Number 2 was associated.
Blood vomiting.
No, was there any associated hematemesis?
Yes, sir.
Okay.
Yes, sir.
Okay. And any postural symptoms, as you said. Okay.
Whether he had any abdominal pain, lower abdominal pain, if he had that.
No, there was no lower abdominal pain. Where do you get lower abdominal pain and melena?
So mesenteric ischemia can cause, because his pain we are assuming could be because of malignancy. That would be hepatocellular malignancy, would be localized in right hypochondriac region. Ischemic mesenteric ischemia could be
whenever there's a blood in the intestine, it will be a cathartic. So you can get sometimes abdominal pain even when you have a blood in this one. Okay. This patient has had melena with abdominal pain. It's a melena. It's a black tarry stones. It's not hematochezia.
Yes, sir.
Melena. Okay.
Yes, sir.
So it could be either be in the upper GI tract, or it could be in the small bowel, or the or in the right side of the colon. Right. These are 3 places. So that is more of it. So intermittent abdominal pain with melena will usually come in a small bowel diseases. In elderly, there's a small bowel disease with intermittent abdominal pain and melena. I'm just talking generally now. I'm not going into the case. So what are the possibilities? Where do you think if there is a small bowel bleed with intermittent pain, what does it suggest? Generally, it suggests intussusception.
Yes, sir. Yes, sir.
Intussusception. Okay?
Yes, sir.
If we have got a melena, intussusception can occur in a small bowel when there is a somebody said disseminated tuberculosis. Very rarely they present with melena unless there is a from the ulcers. Okay, very rarely they present. Amoebic ulcers can produce with melena, but not tuberculosis. So if there is an intussusception, so if in an adult, if there is an intussusception, it's always pathological, isn't it? So if you have intermittent periumbilical pain with melena, that means most probably it will be maybe small bowel. This is beside the case I'm talking to you. And in
Yes, sir.
adults, if you have an intermittent abdominal pain with melena, most of the times it can be an intussusception. And whenever there is an intussusception in adult, it is always pathological. So, and what causes intussusception in adults? There should be a stricture or there should be a mass lesion. Okay?
Yes, sir.
Strictures, as you said, can be ischemic, can be NSAID induced, can be Crohn's, it can be any other malignancy. If it's a mass lesion, it can be a polyp or a tumor. So the tumor can be either adenocarcinoma, it can be lymphoma, or you can get sometimes polypoid neuroendocrine tumors, which can cause intermittent intussusception. So this is what, so when you talk, because you ask me abdominal pain and melena, these are things you need to really think about. If somebody has got classical peptic ulcer disease pain, which comes nocturnally, which comes with hunger pain, and then you have intermittent melena, that could be Hccjune. Intermittent periumbilical pain with melena could be a small bowel disease. Okay?
Yes, sir.
And in a large bowel disease, if there's a pain and melena, most probably somebody said it could be Crohn's, it could be tuberculosis, it could be lymphoma, mostly in the ileocecal region. How does diverticular bleeding present? So how does right side diverticular bleeding and left side diverticular bleeding present?
Would be left side would be some blood mixed, or it need not be melena.
My first question is, which side of the diverticulosis bleed, either right side or left side?
Not sure, but left side, sir, I guess.
Right side. The bleeding, if you have a colonic diverticulosis, the right side bleeds. And most of them, they are hematochezia and they are painless. Left side, you generally tend to get diverticulitis. Okay?
Okay, sir.
Diverticulitis. In the small bowel, Meckel's diverticulitis can come with pain, but they come with a maroon color bleed. They don't come with tarry color. So this is how you differentiate. So elderly man has got a hematochezia. If you have ruled out anal verge bleed, either due to a hemorrhoids or a rectal growth or anything, then if it's a diverticular bleed, most of the times the right-sided colon will have diverticular bleed, will always be hematochezia, and right side bleed more often. Left side, it is predominantly diverticulitis. So kindly look up why you don't get diverticulitis on the right side. Very rare to get diverticulitis on the right side. You have any idea? The right side colon is much more roomy, and then what else is it? The stools are mostly
consistency
water.
Of the stool, yes.
So there's no amount of the fecal earth obstruction is very, very uncommon in the right side. Left side, predominantly the diverticulitis occurs in the descending colon or sigmoid. Commonly in the rectosigmoid junction, because that's where the angulation is this, and a fecal earth thing, and stools are more soft. So this is what you said. I had to explain this mainly because you asked for an abdominal pain. So when you have an abdominal pain and melena, this is a broad, how do you envisage, that is how you go about it. So let's come back to this case. So here is a man who has got an abdominal distension. He's got a pedal edema, he's not able to eat. I presume he's got anorexia, and he's got melena. So correlating abdominal distension, pedal edema, and melena, what will run into your mind? What are the possibilities that run into your mind?
So any GI malignancy.
Good.
Maybe the
GI malignancy, which one?
So
GI can be esophagus, it can be stomach, it can be periampullary, it can be small bowel.
So CA colon.
Most importantly is if somebody has come with ascites, somebody has come with a pedal edema, and come with a teres, most is the gastric malignancy, number one. Because you need to correlate with ascites. Okay? Occasionally pancreatic malignancies can come. or patient may have a chronic liver disease. This is how you think about it.
Yes, sir.
Okay, if you think a GI problem and you're not able to do melanoma, this could be, if you think this is going to be a gastric malignancy, most commonly it can be a CA stomach, where can come with patient can come with malignancy. Periampulary carcinoma, but ascites comes later in periampulary carcinoma, and you can develop in pancreatic malignancy, or you need to think of a patient is having a underlying chronic liver disease.
Chronic
This is
liver
how you
disease.
think. Okay. Let's not bind ourselves to this case, but let's see broadly when a patient comes to you and presents in your OP consultation, what are the things you think of? Okay. So this is what probably I will think about in these situations. So you should know this is how the exam goes on. Okay.
Yes, sir.
We are not too worried about what you make, but we just want to know how you think about the whole thing. So you are sitting in a consultation and somebody walks in like this. This is what you have to think of. Varghese sir, you want to say anything about this?
In the initial elaboration of the history, I think altered sensorium is also something which has to be
Yeah,
thought of
we'll come
because
to
of,
that.
one of the possibilities is the decompensated liver disease. So with bleed, they may have alteration in sensorium. So that need to be mentioned.
Okay.
Another differential diagnosis one should consider is liver disease, wherein there can be a rapid downhill course with ascites edema if there is an outflow obstruction, especially secondary to an HCC. So an ordinary decompensation will not explain the nausea and anorexia. But if there is an underlying HCC, perhaps that may explain. That can also explain the outflow obstruction if it is present. Because pedal edema, if it occurs simultaneously, there has to be an IVC obstruction or something like that. So then in which case everything can be explained. Okay. So that's
Can we go to the
another
next
we
slide?
have to consider.
Can we go to the next?
CLD, yeah, CLD underlying HCC and possibly outflow obstruction.
Patient has no history of jaundice, no history of hematemesis, vomiting, no history of abdominal pain, polyuria, no history of loss of weight, loss of appetite.
He had loss of appetite.
Yes.
Definitely he had loss of appetite. But he could not really say whether he had loss of weight. I don't think he ever this. Okay.
There's no history of breathlessness, chest pain, or palpitations, no history of throat pain, upper respiratory tract symptoms, cough, I guess he had, no history of burning micturition, no history of complementary alternative medication intake, no history of prior abdominal surgeries, blood transfusion, no history suggestive of tattooing or high risk sexual behavior.
He didn't have any altered sensory. He didn't have, as sir asked, there was no history of any altered symptom. So he is just now just presented with some sort of a progressive abdominal distension, pedal edema. He didn't have any, and he had some black tarry stools. No previous history of jaundice. There was no history of any high risk. He doesn't take any. Can you have the next slide? Just no. Can we go back to the previous slide? Anything else you want to ask? No. Second slide.
So any comorbid illnesses if he had diabetes, hypertension?
No. He's a diabetic, but he's not hypertensive. He didn't have any altered sensorium.
Any past history of tuberculosis or any history of alcohol intake?
No history of alcohol. That's what important. No history of alcohol intake. He was a diabetic for the last 15 years, but he didn't have any history of alcohol intake. He didn't have any jaundice. Neither he didn't have any risk for any chronic hepatitis. Okay, but he's a diabetic for 15 years. And then we have to probably complete the nutritional history. In the thing, you need to complete the nutritional history, treatment history. He is on treatment for diabetes with metformin. That's what. Okay.
Okay, sir.
Any other history you want to complete, which is not here? Any others missing? So we need to. And there was no, anyway, I said no hematemesis. So he had no jaundice, He had no hematemesis or vomiting. He had no issue of oliguria, but he had loss of appetite. So here is that's it. Okay.
So
We need the history completion will include nutritional history, past history, any treatment history, and his comorbidities. Okay.
okay, sir.
And you take the nutritional history to find out what will the calories and how much of calories he is taking. So that will complete your history in this patient.
So you would like to know his diabetic status, sir, given that we are thinking of cirrhosis. Whether
Uh, actually, what has happened is his intake has come down. So he had 2 or 3 episodes of hypoglycemia, and the local doctor has decreased his intake or his OHA, and his urine output was fairly okay. Bowel habits were normal except that he had intermittent black stools. Okay, there was no constipation. Anybody else wants to ask any other questions? They can type it up in the box. So let us summarize this case. Just see, 70-year-old patient. Yeah, can you summarize?
so 70-year-old patient with complaints of progressive abdominal distension with 5 to 6 episodes of black colored stools with associated cough with expectoration, uh,
Fever,
cough with expectoration and fever with no history of alcohol
fetal
intake,
edema, and anorexia.
fetal edema.
Positive symptom, positive presentations are 70-year-old man, progressive abdominal distension which he found for 10 days. Then
With history of black
with
tarry
history
stools,
of
10 days,
fetal edema,
fetal edema.
melena, and anorexia, with history of cough and fever for 10 days. So what will be the broad differential diagnosis you'll think of in this patient?
So malignancy. One of the DDs I would like to keep as first DD I would like to keep as hepatocellular malignancy, considering his
The first thing you want to think that he may have a chronic liver disease.
chronic liver disease. Yes, sir. Could be NAFLD related, given his long-standing diabetes status.
So you think first diagnosis because he has edema and this one and anorexia, you think this first thing diagnosis is a decompensated chronic liver disease.
Yes, sir.
Number one is decompensated chronic liver disease. You need to say, I want to think of in the presence of ascites,
And melena.
of fetal edema, melena, progressive anorexia. You want to think first thing is a decompensated chronic liver disease, the etiology of which could be
NAFLD related cirrhosis.
NASH related cirrhosis.
NASH related cirrhosis. Second could be a chronic viral hepatitis.
Good. Third, can you always assert, Verghese said, Bhattacharya.
So autoimmune also we can think, given
Very
though he is a male.
70-year-old man coming with autoimmune, they don't come dramatically like this. Okay. And do you think he might have a superimposed malignancy?
Yes, sir.
What malignancy?
It's a liver malignancy with pulmonary mets, maybe because the lung is one of the very common sites of liver
Now,
metastasis.
you think this is hepatocellular carcinoma?
Yes, sir.
So
Hepatocellular.
what are the malignancies which can occur in cirrhosis?
So hepatocellular carcinoma, cholangiocarcinoma,
Intrahepatic cholangiocarcinoma. So you
intrahepatic
think the
cholangiocarcinoma.
superimposed malignancy on a decompensated liver disease?
Yes, sir.
Okay. Etiology of liver cirrhosis could be NAFL, could be viral, could be hemochromatosis, and it could be Bhattacharya.
Bhattacharya, yes, sir.
Bhattacharya. Is Bhattacharya a forerunner for malignancy?
Yes, sir. It can cause malignancy, sir.
So what is the difference between a nodule in hepatitis B and a nodule in a Bhattacharya?
So usually the nodules in Bhattacharya are regenerative nodules, but if the lesion or if the nodule is more than 2 centimeters, it needs
So what will be
evaluation.
Is it very easy to pick up a malignancy in Bhattacharya?
It's difficult, sir. Imaging wise, it's difficult, sir. especially in smaller
Basically,
nodules.
that classical enhancement, we may not get it early, and most of them may have a pseudo tumor appearance. Okay, so every nodule may not be a malignancy in Budd-Chiari. That's one thing we have to see. So it's difficult to pick up. So if you see a nodule in a patient who's got cirrhosis and hepatitis B, more or less you may be dealing with either a dysplastic nodule or HCC. But in Budd-Chiari, you can always have a pseudo tumor. So you've got to have a very high risk of suspicion. As you said, if the nodule is more than 2 centimeters, this thing. And it is also difficult to sometimes biopsically prove a HCC in these patients. Okay. Okay. So you think first is DCLD, this is the etiology and malignancy. Second,
So other GI malignancies like CA stomach.
no, he has got ascites now. So you think this ascites could be malignant?
Yeah, it could
No,
be
you need
malignant
to
or
clear,
could be.
and you should say that other cannot be GI. So he has got. So you will say that the cause for the ascites, the first thing I think is a decompensated quality. This is the etiology, and I think this is superimposed HCC number 1.
Yes, sir.
Number 2, the ascites could be non-hepatic. Okay, so it could be probably a malignant ascites. If this is a malignant ascites, what are the probable primaries you will think of by order of priority?
CA stomach.
CA stomach, number 2.
And CA colon, sir. Or
CA
CA head of
pancreas,
CA head of pancreas.
CA colon comes, ascites comes much later. Okay,
Okay, yes, sir.
then these most are common. CA colon also will come, but they come much later. They come symptomatically, they come much better earlier in CA colon before they develop ascites. Whereas in stomach, they can be dyspeptic for a long time. They can have a malignant ascites, and then you will find that there is a small gastric. So that is what is most important in this. So CA colon.
I think in view of the presence of melena, it's better not to say about CA colon, no?
Yeah.
Yes.
So it's better to rule about CA stomach is the first.
Stomach will be safer, liver will be safe. Even
Safe.
pancreas will be little unsafe.
Little
Because
this one. Okay. Okay. If it is only moderate ascites, can it be anything else? Patient has got productive cough, ascites, and a pedal edema.
Could be ascites could be because of portal hypertension itself, sir. Need
No,
not
no,
be
no. Talking about I'm leaving out liver disease. We have correct this thing, but here is a man who has got ascites, fever, productive cough, and pedal edema.
tuberculosis.
Huh?
Tuberculosis, sir.
Disseminated tuberculosis.
Tuberculosis.
It could be ascitic and pulmonary tuberculosis. This is another thing which you will think of in this patient. Okay.
Yes, sir.
Anything else you will think of in a patient, an elderly with ascites? Any other peritoneal cause you will think of? We have thought of a chronic liver disease for ascites. We have talked about GI malignancy as a part of it. And then you have thought about tuberculosis as a part of it then.
So congestive cardiac failure, but
That symptoms were not there. No, he didn't have any palpitations.
Yes,
He didn't have distress. Anything else? Something can be there in the tip of the appendix, and then you can get this.
yes, sir. Appendicitis, which might have ruptured, that itself can cause.
No, appendicitis, it ruptures and it gives a ascites. What is the diagnosis?
it's an
Peritonitis.
acute severe event, no? Acute
It's an acute.
appendicitis.
Yeah.
An acute
So
abdomen.
ascites could be due to pseudomyxoma peritoni, and this you can get a neuroendocrine from the appendix, or it could be a mucinous tumor from the appendix. Okay, so these are things you need to think of. Supposing somebody has got ascites like this. So this is how, Dr. Sachin, the exam will go. We will not keep yourself up to the liver and keep asking the liver. So we want to know broadly what do you think when a patient
Yes,
comes to you like this. But yes, sir, can you add on something?
No, I think I have covered everything well.
Everything.
We can proceed.
This is what you think. We want to know if somebody comes like this. Then Of course, you think of congestive cardiac failure, you think of a COPD, all those things in this patient. So that's what I think you need to go ahead with this. So I think it is a thing. Peritoneal carcinomatosis is what we thought of pseudomyxoma peritoneum. That's what I think. Somebody called Taj has put a thing. So these will be the broadest differential diagnosis in a patient who has come to you with these symptoms. Okay? So
Yes,
this is
sir.
how you will argue the case, you will discuss the case like this in the exam. So you have to have a very broad category of differential diagnosis in these patients because we don't know anything else apart from the history. Okay? Yeah. Can we go to the clinical examination? In the exam, we are we are looking at how does your mind run if a patient sits in your consultation. Okay? Somebody raised a hand, please. Go ahead, please. Somebody raised a hand. Can they go ahead, please?
Dr. Joe.
Okay, proceeds.
So on clinical examination, the height of the patient is 155 centimeters, weight of the patient is 60 kgs, body mass index is 26 kg per meter square. He is conscious, oriented.
No, Dr. Sachin, what do you think about the BMI?
So we would like to get a corrected BMI, sir, given that he has got ascites and pedal edema both. We'll subtract for mild ascites 5%, moderate ascites 10%, and for pedal edema 5%. So we'll subtract from the weight and calculate the corrected BMI, sir.
Yeah, in this particular case, I think we'll have to say the corrected BMI. Okay.
Yes, sir.
Okay.
So on examination, he is conscious, oriented, or febrile, pallor is present, edema is present, there's no icterus, there are no peripheral lymph nodes, there's no clubbing, blood pressure is 110 by 80 millimeters of mercury, and the respiratory rate is 86 per minute.
Pulse rate.
Pulse rate, yes,
Pulse
sorry.
rate.
Pulse rate is 86 per minute.
Okay. Maybe when you have a chronic liver disease in the general examination, finish off the stigmata of chronic liver disease on signs of internal malignancy.
Malignancies, yes, sir.
All the thing you need to cover up in these patients. Okay?
And sarcopenia status would like to know, sir.
Sarcopenia. Then also give the nutritional status. Okay?
Yes, sir.
This will cover up the general examination. Can we go to the next slide, please?
For abdomen inspection, it was soft. Epigastric fullness was present. Hepatomegaly was present. He had mild splenomegaly. Free fluid present. Bowel sounds present. Cardiovascular system S1 and S2 were heard. Respiratory system normal vesicular breath sounds. Central nervous system no focal neurological deficit.
So he had some epigastric fullness. Hepatomegaly was there. In fact, here the left lobe was firm. The left lobe was more than the right lobe. Mild splenomegaly. There was moderate ascites.
So the surface of the liver can give us a clue whether he had, if it is completely nodular, it could be because of malignancy.
It's a firm liver, that's it. The left side of the thing was firm. Okay.
Okay,
Right
sir.
side could not be made up. So when you have preferentially left lobe of the liver is more than the right lobe and it's got a spleen.
Mild
ascites.
splenomegaly is
So that gives you a clue that this could be
total hypertension related or cirrhosis, sir.
could be a chronic liver disease
Chronic liver disease
with cirrhosis and probably a portal hypertension. Portal hypertension is characterized by the presence of ascites and
splenomegaly, sir.
pneumonia. Okay. And he had moderate ascites, moderate to large ascites. And you would look for any distended abdominal veins.
Yes, sir.
So mention about distended abdominal veins are present on and any back veins. Okay. That is very important. Okay. The CNS generally look for, when you examine central nervous system in a suspected chronic liver disease, make sure you look for
Any flaps are there or not? Any tremors are there?
otherwise minimal hepatic encephalopathy also needs to be looked up, and you need to look for any ataxia, and you also need to look for any post-colon sensations. All these are important when you say about neurological deficit. If the patient is an alcoholic, then you should need to, some people may expect whether you looked at the size of the heart. So you may have to, supposing somebody has come with alcoholic hepatitis with an ACLF or something, does he have an associated cardiomyopathy? Some examiners are keen on that. Okay? Okay?
Sir.
That's what I think you need to see. And in the respiratory system, supposing you want to do a respiratory examination on a patient with chronic liver disease, what are things you want to look for?
Say if there's any reduced air entry on the right side, given for
First is in respiratory, you look for a clubbing.
clubbing. Yes, sir.
If a clubbing is present in a chronic liver disease, it tells what?
So hepatopulmonary and portopulmonary
It could be
syndrome.
hepatopulmonary. It could be hepatopulmonary syndrome. Number one. Number two, what else you look for in cirrhosis of liver in respiratory?
So to check for hepatic hydrothorax.
Look for hepatic hydrothorax. Okay. That's what you need to look for. Okay.
Yes.
Then, if the patient has got clubbing, you also do a bedside. What is the other corroborative thing you can do on the bedside for HPS?
Sir, orthodeoxy if he's having these.
Orthodoxia. Okay. Take a simple measurement of saying the line. So these are things. Hepatic hydrothorax, how is it? Is it bilateral or unilateral?
So can be both, sir. More common on the right side. Can be bilateral also, sir.
Tell me the percentages.
I guess it is 60% on the right side and 40% is bilateral, sir.
60% is on the right side. 30% can be on the left side. Bilateral can be about 10%. Okay? Or it will be 2/3, 1/3, 1/3. 2/3 is right side, 1/3 is left side, 1/3 can be bilateral. Okay?
Okay, sir.
Okay. So if you have hepatic hydrothorax, what does it imply?
The ascites, it will be more commonly seen in tense ascites. It implies there is a diaphragmatic currents.
Tell me, yeah.
So hepatic
What
hydrothorax.
is supposing somebody comes with a large hepatic hydrothorax? What are the implications or the impact on the disease progression?
So it implies a poorer prognosis, sir.
It carries a poor prognosis. Then it carries a very poor prognosis. Okay, so you need to go for a early transplant.
Yes, sir.
Okay. So these are things you generally look for if a patient has got a chronic liver disease. Okay. Okay. So at the end of the history, do you have any clue? You want to change your diagnosis or you want to tell your diagnosis?
So first diagnosis I would like to keep as decompensated liver disease. With,
Decompensated chronic liver disease.
decompensated chronic liver disease, cirrhotic, decompensated in the form of ascites and
Decompensated chronic liver disease, cirrhosis of liver.
cirrhosis of liver, and probably a hepatocellular malignancy with
With a superimposed liver cell cancer or a hepatic malignancy or HCC. That's what you're saying.
yes, sir.
Huh?
Yes, sir. With maybe a pulmonary metastasis, sir.
Okay. The cough can be either due to a pulmonary metastasis or it could be due to
Or the
HCC.
ascites also.
Okay. So this is what you think of. Do you still want to think of another diagnosis, any other diagnosis?
So could be a the cough.
Where else can you get? Where else can you get anorexia, ascites, splenomegaly?
So all of this itself can be explained by cirrhosis itself. Cirrhosis can have decreased food intake because of tense ascites.
Okay.
They can have weight loss and can have cough because of the tense ascites. And melena itself can be explained by portal hypertension causing upper
Good.
GI bleed.
Okay. Actually, he was sent to us because he had one ultrasound abdomen which showed surface nodularity of the liver and ascites. Okay, so they because he went to the local doctor because they were diabetic. They took an ultrasound, and the ultrasound showed evidence of surface nodularity of the liver and ascites and mild spinova. So he was referred as chronic liver disease. Agreed. So I think with these findings, I think you're fair enough to think that this patient has got a chronic liver disease. We have already discussed the etiology, and then we are suspecting a malignancy in this. Okay.
Yes, sir.
Okay. Can we go for the investigations? Yeah.
His hemoglobin is 10.2. WBC count is 10,000. Initially, it was 16,000. Latest is 10,000. Neutrophil 63%. Monocyte 11%. Lymphocyte is 21%. Eosinophil 2%.
This is okay. We are looking at PTINR and platelet and hemoglobin. Okay.
Okay, sir. Platelets 1,50,000. PTINR is 1.2 within normal range, and random blood sugar is 150 mg per dl, sir.
Okay. It does not give much information, but the only thing the platelets are still well preserved. Okay.
Yes, sir.
And PTINR was 1.43, PM to 1.2. Okay. What are the next investigations you want?
So liver function test.
Can
And
we have the next slide, Bhargav?
So total bilirubin is 1.2, direct is 0.8. Liver enzymes AST and ALT are normal. Total protein is reduced. Albumin globulin ratio is 2.1 by 3.1. GGT is within normal limit. Alkaline phosphatase is normal, and urea and creatinine are normal. And sodium is 135, potassium is 3.8.
Okay.
So his total proteins are reduced here. Other parameters of AST, ALT, bilirubin, alkaline phosphatase, and renal functions are normal, sir.
So generally the bilirubin is normal. There is AG reversal,
Yes, sir.
and he has got no AKI, isn't it?
No AKS. Yes, sir.
So please, all of you, check out how do you define AKI in the presence of cirrhosis of liver with decompensation. Okay. So what else you want next?
So an ultrasound abdomen.
Ultrasound abdomen, they already had done it.
So viral markers.
You want the viral markers? Can we go ahead, please? We did ascitic fluid. It's a high SARC low protein ascites. We are thinking about no evidence of SBP, and the cultures were sterile. That's it.
So presence of any
So-
malignant cells in the cytology.
Negative.
For fever workup, tropical workup was negative. Blood and urine cultures were negative. Sputum analysis showed gram positive cocci with gram negative rods with no organisms. Sputum culture was sterile. Sputum for gene expert and ZN stains were negative for tuberculosis.
Tuberculosis. Okay. You want some viral markers?
Yes, sir. Hepatitis B and hepatitis C mainly.
Can we have the next slide?
So his hepatitis B surface antigen was positive. Viral load is around 6 crore 64 lakh 41,000 international units per ml. Hepatitis C antibodies were also positive. HCV RNA viral load was 4 lakh 27,000 international units per ml. HIV is negative. TSH is normal. Serum ceruloplasmin is 25 in normal range, and FLP is normal, sir.
So what do you interpret here?
He is having a hepatitis B and hepatitis C co-infection.
Co-infection.
Explain the cirrhosis and in the given patient, sir.
So probably hepatitis B and hepatitis C, both he's got a co-infection.
Yes, sir.
And he has been having a co-infection with this. And he just decompensated in 10 days time. Prior to that, he was quite okay. That's what he said. Isn't it?
Yes, sir.
So what could have caused decompensation?
So given his high viral loads, it could be a viral reactivation or a malignancy which could have caused to a
So you
early
said there's a viral reactivation. If we have had a viral reactivation, you think there's something which will tell you here that there is no there was no recent reactivation.
there's no jaundice, sir.
Yeah, there's no high bilirubin. What happens to transaminitis in the reactivation?
So the liver enzymes would go
Goes
up.
up, and they will, if they are cirrhotic, they'll decompensate, and you would not have expected a normal prothrombin time.
Yes, sir.
So probably this has been going on for some time now, and he would have now decompensated due to what's the next possibility?
Development of hepatocellular carcinoma, sir.
HCC. Okay, so there's a clue here. Okay, so he's got a HBsAg and HCV co-infection with a very, very high viral load.
Yes, sir.
So which is, when you have HBsAg and HCV, which becomes more dominant?
So hepatitis B, it will cause suppression of HCV replication, sir.
Or it will either way around. Generally, one will become more dominant than the other, and you can hear that the viral load of hepatitis B is higher.
Right. Yes, sir.
Does the viral load in hepatitis C correlate with the progression of the disease?
No, sir.
How does in hepatitis B?
Sir, it actually depends on the class or the
In
phase
hepatitis
of.
B, does the viral load influence the progression of the disease in hepatitis B?
Yes, sir. Because one of the targets for treatment of hepatitis B is to attain low viral loads.
No. Hepatitis B, does the viral load impact on your treatment and progression of the disease? It does, isn't it? It does. You don't treat if your hepatitis B is less than 2,000 international units in E antigen, right? Or you don't treat it, don't treat unless it's more than 20,000 E antigen positive.
Yes, sir.
But in hepatitis C, there's no correlation between the viral load and the genotype. That's the most important thing. So any viral, if you're non-cirrhotic, in hepatitis C, any viral load or genotype, you still treat it.
Yes, sir.
In hepatitis B, if in a non-cirrhotic, you keep doing them, you do it keeping the surveillance, look at the viral load, then start the treatment. These are two things that this thing. Okay. So, but here you find in this patient, both the viral loads were pretty high in this patient. Okay.
Yes, sir.
You want anything else on this?
So would like to do a CT scan of the abdomen
You want
and alpha
fetoprotein?
fetoprotein levels. Yes, alpha fetoprotein levels and a CT scan of the abdomen.
On the slide, please. Next slide.
Urine examination was normal.
Look at this. Alpha fetoprotein was 3.25, CA99. We just sent this on the day one when you had the differential diagnosis, and all these three are normal. CA99 was mildly elevated. If your CA99 was elevated in a patient with cirrhotic, what do you think this could be?
It could be an intrahepatic cholangiocarcinoma.
Very good. It could be an intrahepatic cholangiocarcinoma. Okay. Okay. What do you want next?
So a triple phase CT scan of the abdomen.
Can we go to the thing? Next thing. This was CT. This was a CT which was done outside. Okay, he came with a CT which was done outside. You know what I'm saying? So can you go ahead? Can you go? No, please. Read the CT, please. Can you go by the previous slide, please? Yeah.
So there is evidence of chronic parenchymal liver disease with a hypodense lesion in segment 5 of the liver of 2.7 by 1.8 centimeters with arterial phase enhancement and washout in delayed phase and enhanced portal hilar node of 7 millimeters. There's moderate ascites. There's no evidence of local metastasis, portal splenic, and superior mesenteric veins were normal, sir. So he has a single nodule which shows classical arterial enhancement and delayed washout pattern with no vascular or extrahepatic spread, sir, which likely suggests hepatocellular carcinoma, sir.
Okay. So when we looked at a CT, the radiologists were not too convinced about this clear-cut washout, a delayed phase, and this CT came out, so they were not very happy. So we went ahead and did one. Can you have the next slide? Yeah.
MRI abdomen shows liver surface, shows mild surface nodularity, a fairly defined arterial phase enhancing lesion measuring 3 centimeters by 2 centimeters, 2.2 centimeters in segment 5 of the right lobe of liver. Lesion shows washout in venous phase and shows capsular enhancement in delayed phase. Portal vein measures 11 millimeters, shows normal contrast filling. There is no evidence of intraluminal thrombosis. Spleen appears normal in size.
So what do you think we just got?
So the findings are confirmed of the arterial phase enhancement and delayed phase washout. That is suggestive of again malignancy. But in this we are having the portal vein measurements and splenic vein sizes normal.
Normal. So he doesn't have too much of a portal hypertension. Okay, at least, but there are only from grade 1 varices.
Yes, sir.
And he had ascites, and he's got now 3 into 2 centimeter segment in the right lobe of the liver. Okay, so he has got a chronic liver disease. It's a hepatitis B and HCV co-infection.
Yes, sir.
The recent decompensation because the recent development of HCC now, and he's got ascites. Ascites does not show any evidence of metastasis. Okay, is it common to have peritoneal metastasis in HCC? Supposing ascitic fluid has shown metastasis or malignant cells.
So there is a possibility of rupture intraperitoneal
HCC never metastasized to peritoneum.
rupture, sir.
As you said, the peritoneum can no. Even when rupture, it's more of a hemoperitoneum.
Okay, sir.
I think. Okay. In fact, we had sometimes we have embolized that artery, and later we went and did the resection. Patient did not have any metastasis. It's very cholangioCA can go into the peritoneum. HCC can go into the lung. It can go into the bone. It can go into the brain. Okay. But
Yes,
it does not really go into this thing. So here is a patient who has got a hepatitis B and hepatitis C co-infection, probably, and the probable sour decompensation is not actually the progression of the liver disease, or it could be due to recent onset of HCC. Okay.
Yes,
So
sir.
here is a patient who has got decompensated chronic liver disease, cirrhosis of liver. He has got grade 1 varices. Ascites is secondary to chronic liver disease. He's got HBsAg HCV co-infection, and he's got one HCC in the segment 5 of the right lobe of the liver, which is it. So this SOL, is it within the Milan criteria?
Yes, sir. It is within.
Done.
So you would like to do a chest
Now,
CT test and
three
DEXA scan.
broad steps in managing this patient. How do you manage this patient?
So I would like to confirm for bone mets and chest mets, would like to do a CT scan and a DEXA scan. Once the mets are confirmed, he is a suitable candidate for liver
You don't
transplant.
expect him to see the CT did not show in the back of the MRI did not show any mets anywhere. Okay,
Okay.
and the lung was also infection because of the lung is also his lung cough was also more of infective pathology. Okay, so he doesn't have any bone mets. He doesn't have any mets in here. Always remember, HCC is a slow growing tumor. They don't come with mets like that. Okay.
Okay, sir.
And here is a patient who has got a normal bilirubin, he's got a normal platelet, he's got a normal prothrombin time, but he's got ascites. And he's no AKI.
No AKI, sir.
He's got a small lesion.
So
Give me categorize your approach to treatment.
So one is the treatment of his viral hepatitis B and hepatitis C. We can
How do you
start him.
treat them?
So hepatitis B, given he is a serotic, irrespective of his DNA levels and enzyme elevations, he
He has
needs
high
treatment
DNA levels, so you can put him on.
and take
So he's
care.
70 years old, he's got ascites. What will be your drug of choice?
So entecavir, sir. 1 milligram
One is
daily.
entecavir. What other thing you can put him on?
Tenofovir, alafenamide, or
Tenofovir,
disperwazole.
alphanamide can be put. Okay, so we can give antivirals. And for hepatitis C,
So sofosbuvir and vilpatasvir.
so we treat it like each one will treat it like a monotherapy. So you put
Yes.
him on this one, and then
If the symptomatic management has to be given, sir, if we can
Okay.
start him on diuretics for his ascites and pedal edema.
nutrition and diuretics.
Yes, sir.
He doesn't have too much of portal hypertension, so I don't be worried about grade 1 varices. Okay.
Yes, sir.
Now, so what else you'll do? So what will you do with this tumor?
So for his tumor, given if his CTP status is less than 8, we can think of intervention in the form of
His melt is okay, no? His melt is not too bad.
Yes, sir. If that is there's no if bilirubin is less than 2, we can go ahead with chemoembolization, sir. Transarterial chemoembolization.
You want to do a chemoembolization.
As if
Why not we risk this?
So given his cirrhotic status, depending upon the liver
Platelets are
acidity.
normal. Prothrombin time is normal. Bilirubin is normal. He's got a single lesion, which is less than 3 centimeters. Portal vein is normal. Okay. Can we resect him?
So we need to calculate his functional liver residue by imaging.
How do you see? How do you decide when your resection will give you what percentage of mortality?
So in a normal liver, at least we should have 40% of remaining liver.
How do you look into it? No? So whether you need to know whether if he's got only right lobe, do we need to how many segments? Is it a minor hepatectomy or major hepatectomy? Minor hepatectomy is less than 3 segments resection. Major hepatectomy is more than 3 segment resection. If you don't hepatectomy, then you need to look at the child class and MEL.
Yes, sir.
Then evidence of portal hypertension. If the CTP is okay and your MELD is less than 8 or 9, and if you don't have gross portal hypertension, you can still resect this patient if they are in child age. But this patient has got ascites, so that means he's got a significant portal hypertension. The ascites could also be related, and before you resect on this patient, you need to look at the volumetry of the other lobe of the liver. If it's a minor hepatectomy, probably we could still resect it, but since he has got ascites, we could go ahead and then what will you do on him?
For ascites,
you can do a transarterial chemoembolization.
Yes, sir.
So what is the purpose of doing a TACE on him now?
So it will
We will
prevent
downsize the tumor with the TACE, and hopefully with antiviral, once the viral load comes down, his decompensation will improve.
Yes, sir.
And once his decompensation improves after 1 or 2 months, see whether he is resectable or
Not.
or what else you can do on him.
Say he might need a second session of TACE or
No. See, here is a patient, he is fairly all right. So if we can decompress it and you put him on viral for one thing. Always saying, why should we reduce the viral load in a patient? Why are we so doing TACE now? What are the purpose of doing TACE? Now you want to decompress the tumor. You want to bring down the tumor.
Yes,
What is the impact of antivirals and activity of HCC? If your HCC is very active and you don't downsize it, the impact of virals of the antivirals also is less. So when you have HCC and a very active viral disease, you need to tackle HCC also, either by an RFA or by a transarterial chemoembolization, so that your antiviral becomes very effective. So what do we expect here is when you put them on antivirals, you expect them, once the viral load comes down, you expect him to become better. Okay?
Yes, sir.
Better on the decompensation side. Liver may become better and his response to HCC also will be better. So after you do a transarterial emergency and after he becomes better after 1 month, you can look at him again to see whether you're going to do you can do a minor hepatectomy or a major hepatectomy, or the other option is
So liver transplant. He's a
very
suitable
good.
candidate
Yeah,
for liver
good.
transplant.
So this will be your approach to this patient. Okay,
Yes, sir.
Varghese sir, you want to? Varghese sir.
Like, yeah, I was listening to you. I think you have covered all the aspects of the management. I think this patient has both viral infections. So,
Yeah,
what
co-infection.
will be the approach? We treat one or treat both?
So we would like to treat both of them, sir. And
We
especially
treated,
when we are planning for liver transplant. That,
except that ascites, his LFT, you should tell his LFT is normal. His AG levels are great, but his platelets are good. His
good, yes, sir.
PTINR is also good. So I think the functional comp of the liver is still holding on. So if you aggressively manage the viral load as well as HCC, maybe we will have an option
It
to
helps
bridge him
us.
to either a transplant or a resection later, because his portal hypertension is not much. Before you do, if your portal hypertension, if the CSPI, if he has got a clinical portal hypertension, resection does not become an option. Okay. Okay. No indication of a minor major hepatectomy. What do? If it's a very small lesion, you can do segmentectomy and come out. If it's a major lesion, if you want to receive, you should remove at least more than 3 segments to get a complete thing. Then you say as anatomical resection and non-anatomical resections. More than 3 segments is major hepatectomy. If you're able to get away with less than 3 segments and do a resection, it is minor hepatectomy. Okay. And your outcome of a recession mortality depends upon the child pube, MELD, and the evidence of portal hypertension or a hepatectomy. Can we have the next slide? So that was MRI. You can see a nice small lesion in the segment 5. Can you go ahead again? Next slide, please. So we start him on thing and follow up FFC. Look at this. HCV RNA viral load has has become undetermined in 1 month's time, whereas this has come down from 6 crores to 67 lakhs. Okay.
Yes, sir.
67 lakhs, more than 6 crores. It has come down to 6 after 1 month, and this patient's ascites has completely now come down. So we hope to then go ahead. Next slide. Lesion specific. Next slide. Next slide. So we went ahead and, as you suggested, we went ahead and did a TACE for the lesion now. Can you go ahead? Can you read it up, doctor?
Angiograms revealed a tumor blush supplied by a branch of right hepatic artery. The culprit artery was selectively cannulated using a prograde microcatheter, and transarterial chemoembolization was performed using 60 milligrams of adriamycin loaded Hephaspheres particles. Check angiogram relieved obliteration of the tumor blush with patent rest of the celiac artery branches.
Can you have the next slide? So that is a very selective cannulation of the TACE. Can we get the next slide, please? See, there's a selective cannulation. They went in and they cannulated that area where there is a tumor blush. Can we have a next slide? Yeah, you have completely occluded the selective right hepatic artery branch of the tumor. Okay. So how do you follow up the patient after TACE?
So we can do a repeat triple phase CT abdomen, check for the M-resist criteria for
How many
whether
days
the,
later?
it's around 2 to 3 months later. So
4 weeks later, then you do it again after 3 months.
yes, sir.
So 4 weeks and 3 months, that's what the protocol is. 4 weeks and 3 months later, and you see there is any, and so once you do a repeat CT, what are the things you want to look for?
So if there's any enhancement in the chemoembolized nodule, and if there's presence of
Now,
any
what
new
is the
nodule.
suggestion now? So here, now so he had ascites, so we couldn't do an RFA. So we just did a transarterial chemoembolization. And we kept him on antivirals. He has now he has completely compensated. Ascites is gone. Okay, we have not repeated. He's due for next CT only on June 12th.
Yes, sir.
So in the CT, the repeat CT, what are the things you want to look for? So you want to look for any residual
tumor. And
is there
any new
any
lesions.
enhancement or there's no recurrence? Okay, so that's what you think, and you should always look for a site. So we plan to do a thing, and at the end of 1 month, if his Child-Pugh score is okay, he is completely off ascites, then we could probably plan either a resection or a
transplant.
transplant on
Liver
him.
transplant.
Okay.
Yes, sir.
So post-transplant, supposing he has a very mild enhancement, okay, in the periphery, but there's more, the second time there's a more enhancement in the central. How will you manage? He doesn't want transplant.
So we can do a second session of chemoembolization.
So you can now, when you have a peripheral enhancement, but there's more enhancement in the center, what you do is you can combine a TACE with an RFA.
Yes, sir.
The RFA will take care of the central thing, and the peripheral thing can be taken care of this one. Okay.
Yes, sir.
But if the residual tumor is there, we can give an option of second TACE and this one. So you want to compare TACE with transplant. How will it go on?
So depending upon the underlying liver status.
Now this patient, he has completely obliterated after 4 weeks. There is no residual tumor. His viral load has come down.
So given his age of
how many years the TACE will equal to transplant results? After 2 years. After 2 years, again, the transplant results are much better than the TACE. Okay. So you need probably offer him a transplant. If he doesn't work a transplant, we can go up to 2 years. We have always salvaged patients up to 2 years. After that, it's difficult to salvage these patients. The most important things about this is you need to treat the antiviral activity very, very this thing. So, supposing after 3 months, so what will be the duration of hepatitis C treatment? What will be the duration of hepatitis B treatment in this patient?
So treatment of hepatitis B would be lifelong, given his cirrhotic status. And for hepatitis C, we can treat him for 6 months, 3 months. And
3 months, he's already cirrhotic. So if 3 months plus ribavirin. Otherwise, if it's going to be only without ribavirin, you may have to go to
6 months.
You got to go to 6 months. Okay.
And check for if he has attained sustained virological response.
Varghese, sir?
Yeah, I think that's the correct approach. You have to give treatment for both. And treat the tumor and wait for the response. And if he improves, then we should offer him further either hepatectomy or transplant.
Transplant.
Yeah.
If you want surveillance, he says, no, I don't want anything. And how will you go into surveillance?
So we can put him on an ultrasound as well as alpha fetoprotein surveillance.
What is the recent thinking of surveillance in HCC now? Is it ultrasound or something else? Have you heard of abbreviated MRI? Abbreviated MRI. Please look up. Abbreviated MRI has come into picture to see.
Maybe they can expect a short note because there's a recent guideline now.
Recent guidelines. Abbreviated MRI is what is now recommended to do a surveillance on him. So this is a classical case of a chronic liver disease having a hepatitis B and C co-infection, decompensated because of a single hepatocellular carcinoma. He had a very high viral load. He had a fairly good child status and a low melda with a normal platelet and this thing. In HCC, the platelets are low, it carries a poorer prognosis.
Oh, yes.
If the patient cirrhotics has got low platelets, the incidence of HCC is much higher. Okay, this is a correlation. And what we did is, because he had ascites, We salvaged him right now at the present with a taste, and hopefully, if agreeable, either we look for a resection or a liver transplant. Meanwhile, his hepatitis C treatment will go on for 6 months. Hepatitis B will go on lifelong. So, if his viral load, how much you expect the viral load to be before you do a transplant on, because he's got hepatitis B? I would prefer to have a nil viral load when you have it. And post transplant, how do you treat hepatitis B and hepatitis C? So, this is what you need to know.
So a hepatitis C, if we have achieved undetectable RNA levels, that won't need
But when you
treatment.
put on immunosuppression, can go up.
Yes, sir.
So, what is the most dangerous complication of hepatitis C after liver port transplant?
So, second malignancy, sir. Malignancy
No,
in
no,
the
fibrosing cholestatic hepatitis. They can develop jaundice, they can have cholestasis, and they can die in 15 days' time. That's why we keep checking up the HCV RNA viral load. And hepatitis B, if the viral load is low before transplant, we continue antivirals.
right, sir.
Or we combine antivirals with hepatitis B immunoglobulin. Okay, we give a
Yes,
large
sir.
dose of immunoglobulin in the perihepatic phase, then give immunoglobulin every day for a week. So post transplant, you have to maintain a HbA1c of more than 500 at least for 4 weeks. So these are all the implications in this case. Okay. So this is a 70-year-old man, hepatitis B at the co-infection, chronic liver disease, low melda, normal platelets, not much of portal hypertension, and decompensated to HCC, now salivate taste, and is on antivirals. So you should know all about it. If your case comes like this, we will go on to this length of examining you, what can happen, right?
Yes, sir.
Okay. Varghese sir, your final comment, sir?
Yeah, I think this is a classic case which will be kept in the examination. Decompensated chronic liver disease is the examiner's most favorite. The reason is that from day one to your last until your examination, you would have seen hundreds and hundreds of chronic liver disease decompensation. So we don't expect you to make any mistake because the most common case you see in the ward. Okay, so mistakes in management or in the diagnosis of chronic liver disease or any of the problems associated with the chronic liver disease, the tolerance level by the examiner will be low because it's the most common situation you face in your wards. Okay, so you have to be absolutely thorough with all aspect of chronic liver disease. It is different complication management of each and every problem, and there cannot be any excuse. There cannot. I have seen some of the examiners becoming very very annoyed when then the candidate is not able to answer common questions regarding management. Because if you don't say the correct management, the examiners will have a feeling that you have not worked properly in your ward.
The what? Correct.
Yeah, that is what they feel. Okay. So
If
chronic
you
liver
are
disease,
not thorough in chronic liver disease and management, then you are in trouble actually.
yeah. And almost invariably I find one case will be chronic liver disease. That because that's the most easily found case in the hospital, no? Okay, so chronic liver disease, one has to be thorough and 50-50 chance that it will be there in the exam. So all aspect of chronic liver disease, you have to be thorough. Okay. It was a good case. It's a good case, and this is a usual type of case which is kept in the examination. And the reasons for a recent decompensation, and mostly it is HCC.
Uh, the point here is just want to tell you is that we take the case like this only. So, patient has come to ascites. So, we will look at you at the presentation of the history and saying how broadly you think about the differential diagnosis of ascites. Then, how do you narrow down after your clinical examination? Then, how do you manage and then how do you interpret the clinical investigations? And how do you broadly manage these patients with all aspects?
Yes, sir.
And what are the options of treatment available? So, you should be thorough in these cases. Okay?
Yes, sir.
Good.
Thank you, sir.
Sometimes sometimes the candidate will be little hesitant to answer because if you have any doubt, because sometimes we will ask a theoretical question or general questions. But then you have, if you are not very sure about the question, please ask: are you asking about this case or in general? Because in the evolution of the discussion, we ask questions not pertaining to this particular case also. Okay, So you should not get confused because we can ask you questions regarding this case or even general question to know your breadth of knowledge. Okay.
The webinar will begin shortly. Please remain on the line.
There's a question.
What is it, sir?
Role of PIPCA.
Yeah,
There are some questions in the chat box. Professor Venkat, can you open the chat box?
the chat box, sir.
Yeah. Are you able to see?
I'm not able to see, sir. Can you?
What is the indication? What is the indication of minor hepatectomy and major hepatectomy?
No, it is depending upon the size of the tumor.
webinar will
The
begin
tumor
shortly.
size is
Please remain on the line.
very low. The tumor size is less, and you can get away with 2 segments. That's called a minor hepatectomy. But if the tumor is bigger, and then you need to increase, that depends upon the anatomical localization and the relationship of the tumor to the portal vein. Then you want to do, if you're able to do less than 3 segments, it is minor hepatectomy. If they do more than 3 segments, if it is major hepatectomy. If the MELD is less than 9, then in a minor hepatectomy, again the prognosis is good, and the mortality may be less than 10%. But if you do in a major hepatectomy, if the MELD is more than high, then you have to say that morbidity mortality may be close to 30% in hepatectomy in patients with cirrhotics. Okay.
Then another thing is that the intermediate stage has been expanded. So everyone should know that you may get some questions, when theory question about that intermediate stage and its new subclassification and the approach to management has changed from the older BCLC. So that also one has to be thorough. Can you highlight on that, Professor Venkat?
Which were intermediate risk.
Yeah.
Yeah, that is basically we need to look at whether it's a low risk malignancy, high risk. The high risk can always be everything if your AFP is very much elevated more than 1000, and if you have more than a higher this thing of tumor. But sometimes if you have an intermediate risk, you may not do a hepatectomy much earlier, but you may do it. When you may do it, you may have to probably downgrade it to less than. So if it is very high risk, what we do is sometimes we downgrade it, bring down the AFP to less than 400 or 500, and then you try to operate or do a transplant on these patients. So this can be achieved either by a TACE or something.
The downstage, yeah, downstaging is something which should be
very
actively thought of. Yeah.
Downstage it, and so it depends upon the thing. In the Western countries, if your AFP more than 1000, you downstage the hepatectomy, and then you can always go in for you can downstage the hepatectomy, downstage it and bring down to below 500, and then before you start the treatment. But in Asian population, the Japanese say anything above 400 also you do a TACE, bring it to 200 and this thing. So the Asian population, both the Taiwan and Japan says then you please downgrade it to less than 400 or less than 200 before you plan on a definitive treatment.
There's a question on continuing anti-HCV treatment.
We don't
And
continue anti-HCV after 6 months once they're achieved in SVR. But we'll always follow them up with the HCV RNA viral load, probably very frequently when they are on immunosuppression. The moment the HCV RNA goes up, we put them on antivirals. And whenever you put them on antivirals, we always look for the interaction of these antivirals. Some of these are protease inhibitors. Protease inhibitors can have a very severe interaction with tacrolimus or the immunosuppression. That is what you need to really look into it, especially protease inhibitors used in HIV and HCV. You got to be very, very careful because they can have severe lactic acidosis in these patients. Okay.
in a person with the normal AFP, is there any role for PIVCA for the
No,
diagnosis?
I don't think so. We don't go unless both your CT or MRI is not able to say whether this is a HCC or not. I don't know. Now, according to BCLC, if you are not very sure of CT, now its recommendations to go for another. You can go for another imaging, which generally in 90 to 90 will pick up the lesion. So MRI will be able to tell you that this is a HCC or not, if your thing is not. Okay. Sometimes what happens is when there's a small tumor and there's a portal vein thrombosis, there can be a diffuse perfusion attenuation, which may not be able to give you a good enhancement. So you can do an MRI, and most of the times you're almost always diagnosing HCC by imaging.
And
The
I think there
Japanese
should be
use
also,
PICA very commonly. Japanese use PICA in their guidelines for HCC.
and one should also know what is LIRADS, no? Because
Like
that also the examiners may ask about the
them ask,
LIRADS. LIRADS, it may come as a short note also.
like.
I think
So
that's
I
an
think
chat
the
question.
learning objectives here are the HCV and HIV co-infection. How do you broadly discuss about the ascites? How do you narrow down the diagnosis, and how do you manage these patients? And you should know all about HCC and some of the trials, and you should know how do you prognosticate the impact of resection or liver transplant on these patients. Okay.
And if you want to get more marks, please learn the various trials. They ask named trials.
Yeah.
The examiners will try to know whether you know more. So they may ask you the names of various trials, and
And
if you
now,
can.
in HCC, they will ask you about systemic therapy also. Systemic therapy, now initially it used to be, you should know what is the first line of diagnosis. No? First line management is, what is the first line drug now?
So bevacizumab and atezolizumab, sir.
Pardon me?
Bevacizumab and atezolizumab, sir.
That is the first line. Second line is
Lenvatinib and sorafenib, sir.
sorafenib and regorafenib, and then you have the immune this thing. You have the immune checkpoint inhibitors now. Okay, immune checkpoint inhibitors is what we do. Fibrosing cholestatic hepatitis is a recurrence of hepatitis C in transplant patients. First, initially, we used to see this in renal transplant patients. Hepatitis C will have renal transplant patients, and suddenly after 15 days or something, once you put them on immunosuppression, there will be an explosion of increase in viral load. Patient can have a progressive jaundice, cholestatic symptoms, and they rapidly get into the liver failure. In these times, when you are high bilirubin levels and you have a high bilirubin level, we were not able to give interferon to these patients. Now, with the onset of DAA, we are able to salvage majority of the patients. Previously, in the absence of the direct antivirals, it used to be 100% mortality in these patients. But now, once you see a viral load is going up, you can immediately start them on DAA, and you can salvage almost 90% of these patients. Fibrosing was first seen in renal transplant patients who had hepatitis C and renal transplant. So that is what they. Progressive jaundice, rapid cholestatic symptoms, decompensation, and death. But now, with the onset of DAA, we are able to treat these patients. Okay.
Okay, I think we have come.
Okay, sir.
So that was a wonderful discussion. Thank you, Professor Venkatesh, for that elaborate discussion. And thank the presenter also, Sachin Chakravarti, for a good presentation.
Yes, sir.
Should we go to the next case, or?
It's already 9:25.
Okay. Shall we take it to?
Next week, no? Next Thursday. We'll do it next week.
The next case, I think the next Thursday.
You have a problem?
I think next Thursday, Jayanti Madam is also not there. So
Okay.
our session will come on. Our session will.
16th.
Our session will come on. It's supposed to have come on 9th and
9th.
23rd.
So we'll have to 1 week later, 16th.
Yeah. So we can no our session has to be on 9th and 23rd.
Yeah.
But Jayanti Madam, and I think there is some sessions in Chandigarh going on. So
Okay.
our session will have it on 23rd.
23rd.
23rd. Okay,
Alright.
sir. On 9th, there is some sessions in regarding NAFLD in Chandigarh. So
Okay.
Madam will be this thing. So students, if they can attend that session.
Okay.
And so our session will be on 23rd. Okay.
Okay then. Bye.
Okay, sir. Thank you, sir.
Okay. Bye. Good night.
Thank you, sir.